Mr. Kibet, are you with us? He'll be joining us shortly. Now we'll go directly into what we are discussing today. You said we'll be talking about effective communication in clinical practice. Mr. Siele, Karibu, you can share your presentation and you go right in. Dr. Karingo from Kenyatta National Hospital will be taking you through coordinating this session. Karibu.
Thank you so much, Doc. So I think I'll really jump right in. I'd like to highlight the areas that I'll just talk about. For me, I think normally I prefer to start with this aspect of the mindset, and I'll just highlight with 2 slides why the mindset is important, even before we talk about the different types of communication. And I'll give my perspective in terms of communication during consultation, which I think is important. And just in alignment, I'll finish with 1 or 2 comments regarding how this really golden thread links to what is our theme, which is engage, involve, and partner, as I've put it, for effective communication. I think for most of the participants that we have today, you may have come across this topic on mindset. We have 2 types of mindset, basically, growth versus static mindset. And as we've always said, it's really important at any one time to ask yourself, which mindset do I tend to portray the most? A growth mindset is anchored on the belief of continuous improvement. And in a growth mindset, you don't hide the deficiencies, as we like to say, you overcome them. But what is more important is that in a growth mindset, you stretch out new possibilities. Now, on the opposite side, a fixed mindset believes that your qualities and capabilities are cast in stone. And in a fixed mindset, there's little you believe you can do to change. I think even as we talk about today's topic, it's important to highlight that as much as possible, the recommended mindset that you want to spend most of your time in should be the growth mindset. You'll find that it's easier to communicate in a growth mindset. It's much more easier to listen in a growth mindset. And I think we'll talk about that in the next few slides. Very quickly, as I said, I'll highlight 2 things on the growth mindset. In a growth mindset, you also try different learning tactics. In a growth mindset, you tend to dissociate improvement from failure. And of course, you reward actions and not traits, but more importantly, you place effort before talent. We'll see how this really relates to our topic today. Now, I know, and I think we have such distinguished panelists. I'm sure they will be talking something very similar to what I'm saying, but we tend to start by also highlighting the fact that when it comes to communication, we have 2 types of communication. We have a verbal communication and non-verbal communication. We know that the non-verbal communication represents about 93%, and the verbal communication represents about 7%. Now, why does non-verbal take such a significant chunk of the communication? It's because it also represents the way we stand and sit, facial expressions, the silence that we have in between communications, the eye contact, and gestures, which include smiling, leaning forward, and nodding. And we will see towards the tail end of my presentation that this plays a very critical role when it comes to clinical or effectiveness in clinical communication. Now, in terms of techniques for effective communication, we often talk about 3, which is active listening, reflecting, and summarizing. Again, I want to just get the audience to bear this in mind as we will be talking about this in a consultation room. How do the 3 actually come in? Obviously, when it comes to active listening, it's an essential part of communication. Often we, instead of truly listening to what the other person is saying, we often are thinking about the response that we want to give. In fact, one of the things that we teach in communication is that you need to listen 75% of the time and talk 25% of the time. Why? Because if you look at that component when it comes to communication, it allows you to have a much more better understanding of the person that is talking to you. And I think, as we will see again, I said in the next couple of slides, this is extremely important. Now, reflective listening is a different form of listening also. It's a process of verbally reflecting back what the person has said. It helps the other person to understand what they're saying, also helps the other person to feel like they've really been understood. In reflective listening, you're also looking at whether the other person has really been able to communicate and if you're on the same page, and that is extremely important. Now, of course, one of the things that is extremely important is also summarizing. In summarizing, you use this to check that you have understood the patient's story or issue. When changing topics, for example, or closing discussion or clarifying something, you also use the summarizing technique, and you can also use it to collect your thoughts, just to sort of crystallize everything that you have discussed, and then you're able to show the patient that you have heard and of course respect his or their point of view. And this is extremely important when it comes to communication. Now, probably it would not be fair enough for us to talk about the different types of communication if we don't talk about what are the barriers that we often face in communication. Often it's talking too much. Like I said, it is easier to understand that rule of the thumb that you need to speak 25% of the time and listen 75% of the time. But often what we see nowadays that tends to be the most common barriers is, things like mobile phones. Of course, being critical or judgmental, often it gets the other person to switch off, laughing at or humiliating somebody or contradicting or being disrespectful or lack of trust. That really tends to pose a challenge. Now, for me, that was really sort of just a very quick introduction. And before I talk about the importance of communication when it comes to consultation, I also want to share with our audience today, what are the 5 things that you can really tell that somebody is listening. And because I think listening underscores a very important part of effectiveness when it comes to communication. Number 1 is eye contact, and we'll see that in the next 1 minute. If the person that is that you're talking to, for example, is not looking at you into the eyes, it's unlikely that they are listening 100% of the time. And that's a very important tool. Number 2 is undivided attention. Often, if the person that you're talking to, or even if they are talking to you, if they are busy doing something else, whether they are writing or they are on their phone, it's unlikely that they are listening. Now, of course, from a clinical setting, this really presents a very interesting discussion, because often you will find that the clinician may be busy writing the notes. The question is, would you want to listen first and then be able to write, and I think we'll discuss that in a minute. So number 2, as I said, is undivided attention, and that is extremely important. We've also seen that when it comes to listening, it's important to listen with the heart. Why is it important to listen with the heart? Because you are trying to put yourself in the shoes of the person who is speaking and really be able to understand or to empathize. And that's extremely important. Number 4 is, of course, listening with the mind. And often people forget that this is very critical. You listen, and as a clinician, so that you can be able to interpret based on the information that has been provided. And of course, lastly, listening with the ears. Those are 5 rules that I just want to clarify at this point to underscore the importance of listening. What you want is to make sure that the person that is in front of you is also listening 100% of the time. Now, when you talk about communication in a consultation, one of the things that you want to do is to make sure you're prepared. Ensure that you've established initial rapport to win the patient's confidence, and of course, identify the reasons for the consultation, or be able to state, at least for the patient, this is why you're here for this consultation. What is important is the environment, as we often say, and I believe that we do have within our audience very experienced clinicians. It's extremely important to have a conducive environment, because some people will not be comfortable to talk. For example, if there's probably a very thin, what should I say, separation between many patients, and so they are not confident to talk about their condition, maybe because the curtain, they feel like the other person is listening to what they're saying. So location is important, the room is important, the sitting arrangement is important, even the desk is important. When it comes to the self, of course, as I said earlier on, you need to be ready to listen 100% of the time, and you need to be clear that your body language, as we've seen, plays a very significant part in communication, is also going to portray a positive alignment. In terms of establishing initial rapport with the patient, it's extremely important to greet the patient. And I think, as I said earlier, eye contact is very critical. We see this as being a very common thing that people often forget. It's important when you're greeting somebody to look at them straight into the eye, not to be facing down, to be writing or looking at your file, at the patient file. And at the same time, you're also greeting them. It's important to check the patient's name and call them by name. It tends to ease them up and create a very conducive environment, introducing yourself, of course, your role and the nature of the consultation, obtaining a consent. I believe this is really primarily pretty much obvious, but more important is being able to empower the patient to ask questions and then demonstrate respect and interest. And I'd like to underscore the bit of respect. The patient is critical because what they share is what you will use to make your clinical diagnosis. So being able to make the patient feel that they have been respected is extremely critical when it comes to communication. Of course, I think the others are pretty much standard in terms of confidentiality and being able to do the notes. What you don't want to miss out is the non-verbal aspects. As I said, you need to have a calm approach to patients so that you can be able to ease the tension and the anxiety. Anybody that is going to see a doctor would, of course, be anxious because they don't know what could be wrong with them. The tone of voice is extremely important. We've had cases where, the patients get intimidated just by the tone of voice of the clinician. Now, of course, use of touch is something that I think we used to talk a lot more before COVID. With COVID, I think it's just asking ourselves what would be the most appropriate way to let the patient know that they're really welcome. For some, maybe it's a simple bow, or even it could be, a thumbs up, whatever you use that of course doesn't involve contact at this matter. And the personal space, which often really is a reflection of the arrangement that you have within the clinician's room. Now, one of the things that I'd like to emphasize also is about the way in which we question the patients. Open questions, or what we call open-ended questions, tend to allow the patient to complete the response. It's often advised to be able to have very good communication to avoid interjecting, so that you can allow the patient sometimes to put together their thoughts and be able to communicate that. When you interject, sometimes they lose the train of thought. And of course, they would often be describing how they are feeling, the symptoms, which will have a different words that they are using as opposed to a clinician. So again, you can say that the component of listening really plays a very critical role. You need to be able to listen attentively or use active listening, as you said earlier, and sometimes even silence to allow them to be able to give you a response. That's extremely important when it comes to discussing. In terms of awareness of feelings, I think it's important to know, of course, even as a clinician, how are you yourself? Because your body language may not necessarily be saying what you're saying verbally. And patients also do react to the body language. It's important to differentiate that. It's good to see the patient's body language and what they are saying. Is there a difference? And I think being cognizant of that allows you to know that could there be a message that I could really be missing? We said earlier when we started also, it's important to have empathy, which is really a core part of listening, putting yourself, of course, in the patient's shoes. When it comes to engaging, the patient needs to feel comfortable and confident enough to be able to talk. They need to know that I have, my right to be able to talk and I'm being listened to. That is extremely important. When they feel like what they're saying is not being valued, the patient can, of course, easily switch off. In terms of involvement, as I said, again, I think it's important to have a two-way conversation so that they are also able to hear your opinion when you reflect back, like we said, what you have heard, and they can be able to confirm that, yes, this is true. What you've said is exactly what I actually said in my own words. And being able to partner. I think when the patient feels that as a result of that communication that you have their best interest and you're there to make sure they get the best possible care, they're likely to get more confident and it really even want to be able to discuss much more freely. That's really, so I would say, is my summary in terms of my brief regarding this particular topic. Thank you so much.
Thank you very much, sir, for that timely and quick presentation on effective communication. You've indeed given us a baseline or the basics of communication and how it is important to communicate effectively, the barriers to communication. And one very key thing that I've personally gotten is at the start of your presentation. I've said that there are two kinds of mindsets, the growth mindset versus the static mindset. Either people want to change as things come along. Are we ready for change? Are we ready to communicate effectively? That is growth, or are we those people who want to be static and not ready for change? So thank you for that basis. And thank you our participants also for keeping in touch. For any questions and comments, please feel free to type in the Q&A section and we'll get to it at the end of the presentations. We are now going to go into our second presentation by Dr. Dr. Violet Oketch, who is a mental health specialist here in Kenyatta National Hospital. Karibu, Daktari.
Asante sana, Daktari. It's an honor to follow Mr. Siele's very informative presentation, and he's actually done half of the work for me. I'd like us to just ask ourselves again, what is communication? If you look at this picture, you can see two ladies. And Mr. Siele did say that communication can be both verbal and non-verbal. Communication has been defined as a transmission of information, thoughts, and feelings so that they are satisfactorily received or understood. This is very, very important in the hospital setting. Now, for any type of communication to occur, there's a sender, there's a receiver, and there's a message. Next slide, please. So what is good patient communication? In a nutshell, I would say that good patient communication is communication which is patient-centered. It recognizes that your patient is a whole person who has a body, a soul, and a spirit, a person who is an expert on their life and their illness. They are the ones who are living with the disease. They have certain values and beliefs. They belong to a family or community, and they play multiple roles in society, whether it is as a parent, a sister, a brother, an employer, an employee, and all of those are going to impact the way in which they view their disease and they view their interaction with you and the things that you're communicating with them. In any good patient communication, it's actually an exchange of knowledge and information between two experts. One expert is the clinical care provider, and the other one who has the clinical knowledge, and the other expert is a client or the patient who has the knowledge of themselves, their illness, and the cultural or personal factors that will influence their effective treatment and care. So effective communication recognizes all this and works to overcome possible barriers. Let us look at some barriers that could possibly hinder effective communication. One of the barriers, if I look on the left of my slide, it says that barriers to effective communication include messages that are unclear, incomplete, or difficult to understand. Many times, us in the medical profession, we are accused of using words which are medicalese. You know, the biopsy has come through and it shows that the cancer has metastasized to stage 4, and the patient is wondering, biopsy who, stage what? And because we're so used to interacting with one another, it's important that as we talk to our clients and their family members or their loved ones, that we talk in a language that is understood by your patient or your client, that in a language that they understand, sent over an appropriate medium, and you give them time, as Mr. Siele had pointed out, for provision for feedback, and give them time to be able to ask any questions and confirm with them that they've actually received and understood. They might have also received the information, but it might be ignored because it does not line up with their values, okay? Or the messages might have been misunderstood, because each person, when you talk to anybody, they are receiving the message through the filter of their life experiences, their beliefs, and where they're coming from and where they're standing, especially at that time in their life journey. Messages that are also delivered through automated systems that lack the human element might become a barrier. Messages that are delivered through digital content and satellite content, and actually the various means of communication that we have have actually been used to enhance communication. If you look at the slide on the right, you can see that there are certain things that might hinder communication from the patients.
Hello. Apologies about that. We are getting Dr. Oketch back on board. We seem to be experiencing a bit of a technical hitch, but even as we get back on board, let me ask, in what areas, in what ways have we experienced challenges in communicating to our patients or our clients? Some of the questions I'm seeing coming in here, such that how do we deal with those who are patients or clients who are challenged? Do we have mechanisms in place for disabilities? And how do you deal with some certain types of clients, like aggressive clients? So those are some of the things that provide a challenge. So you can give us some of the ways you've dealt with these challenges, or some of the things that are being done at our particular institutions to help us communicate effectively with our clients. I'll be back on.
Hi, this is Dr. Kibet. Sorry about that interruption. I'm back on air. Hi, I trust that you can hear me now. So I'm back on air talking about possible barriers to effective communication. If you look at the slide that we're looking at that had been set up, you can see that the barriers to effective communication come from either the side of the patient or the side of the provider, and it depends on where they're coming from, their level of education, their understanding, and their own values. But the idea of effective communication is to find a common ground where one is able to communicate with the client at a level at which they understand. So we have seen that in order for us to communicate with our clients or patients effectively, we need to be able to be in touch with our own and their own health beliefs and values, to understand their culture, their personality, and to communicate in a language that they can understand, and also to work on the power dynamics so that we are approachable and we're able to build rapport with them. So there's a model called the RESPECT model, which actually is used in clinical settings to be able to guide us in how to best effectively communicate with our patients. Number one, R stands for rapport. When you meet a client, connect with them at a social level. As we've said, introduce yourself. Consciously suspend judgment, avoid making judgments about things that they say, and recognize and avoid making assumptions. In your speech, be uncomplicated and minimize medical jargon so that you can be able to talk in a way that they're able to understand, and be specific in what you're talking about. E stands for empathy. Anybody who's coming in for a medical review or in a clinical setting has come because they are seeking for your help. So your job is to seek out and understand their rationale for their behavior, even if it might seem erratic to you, to verbally acknowledge and legitimize the feelings that they might be experiencing, and also to communicate with them in a way that your body language is saying that you're actually listening and attentive to what they're saying. maintain eye contact, and speak to them at their level. Sometimes in African culture especially, it is very intimidating if somebody is seated and you're standing and you're talking to them, in which case, kindly let us remember to talk with the patient at the same eye level. S stands for support. We're talking about the respect model of effective communication. How do you support your client? Ask about and understand about possible barriers that might interfere with their taking up the care that you're suggesting or their compliance. Having identified these barriers, help the patient to overcome the barriers and inquire from them who they would like to be involved in their care and whom you can disclose their personal information to. And therefore, I talks about involving the family cares or loved ones if appropriate. And do reassure the patient that you're not just there for them at that particular point, but you are the team member who is taking care of them at that particular time. You're available to help. And if need be, you might need to share issues about their care with other team members, or you might hand them over to somebody else for a different part of their care. If we go on in this RESPECT acronym, partnership. As medical people, we're very, very much used to being in control, but we need to remember that the client or the patient that you're talking to is somebody also who is in control of their life and many different spheres of their lives. And therefore, we need to be flexible with regard to control issues. And the best way of going about these control issues is to forge a partnership with your client so that they understand and you are on the same page, that you're actually working together as partners in care. And therefore, I've written for you this medicine, it is for this condition. Are you okay with taking it the way I've written it? If you have taken it before, might you be experiencing some side effects? How can we navigate them? And if, different issues that come up as we interact with the client, so that they're able to feel that they are also in control of making decisions that affect their well-being and taking up measures that are going to help them to become better. If necessary, we need to negotiate our roles and also find out if they need other people to be part of their care team. Stress that you're working together to address the health problems and you're a team. E stands for explanation. You know, how many times have you ever talked to somebody and you're telling them one thing and they understand something completely different, and yet you're speaking the same language? So much more so in the medical setting, we need to check often for understanding that. We're just talking about the fact that you need to be coming for the clinic on this day and at that particular time. Is that okay with you? Would there be a problem there? And we have just discovered from the test that we did that you have too much acid in your tummy. Okay, tell me what you understand about that. Where could it have come from and what can you do about it? It is important to use verbal clarification techniques such as reflection, asking open-ended questions, and giving your patients ample time to respond and to ask questions. In that way, they feel listened to and heard, and they're actually playing an active role in taking in as partners in care with the healthcare providers. The other thing that is very, very important is cultural competence. Each one of us comes from a certain family or a culture, and we need to respect the patient's cultural beliefs, which might be different from ours. We need to understand that the patient views of their lives and their culture will define the way they respond and will definitely impact the way they respond and the way they take their illnesses, where it has come from, what it means, and how to deal with it. Different cultures and ethnicities have different ways of handling things, but let us also not be so stereotyped as to expect that because somebody's surname states this or the other, that they're going to behave as like everybody else in that particular cultural group. So each person is unique, and we need to respect and understand people's different cultural beliefs, and also be aware of our own cultural biases and preconceptions that might impact the way we're interacting with the clients. One of the things that is important for us to remember is that each of us has limitations in terms of trying to communicate sometimes medical issues across cultures. And if need be, you might need to reach out to a colleague from a similar culture to your client, who would be able to explain to them perhaps in a language or in a way that they understand. One of the things that I come across quite often is because we live in a very, very spiritual country, and I'm talking from the Kenyan context, many times by the time the patient has come to us, they have gone through, see the traditional healer, they have gone to see the pastor, they have gone to see the imam. It's very, very important to see who else is impacting their care and what are the sources of support that they're actually leaning on. And then also, for example, if somebody believes they are bewitched and you are telling them that the growth that they have is a fibroid, then you need to be able to address that. so that you're able to see which is a medical side that you can address and how can you address the cultural meaning behind what they're experiencing. U stands for understanding in cultural competency, in understanding our own personal style and recognizing that it may or may not work with any given patient and accommodating each patient that comes along our way to the best of our abilities. The last letter in the respect model of effective communication is building trust. It's not very, very easy to disclose very personal things that happen to us to other people, and self-disclosure may be difficult for some patients. So as healthcare providers, we need to consciously work using both our verbals and non-verbals to establish trust with our patients and to make our interactions easier for them so that they are able to connect, understand, and the conversation flows back and forth. Well, some of the key things that we can do is keep our sentences and questions short, stay on one topic at a time, explain difficult concepts, and give time for back and forth, give time for feedback, and give time for any other response that the patient might have. Indeed, effective communication is very, very important because medical evidence has demonstrated that there's a positive association between the patient satisfaction with healthcare they receive and their provider's ability and willingness to communicate and empathize with them. Indeed, when clinical outcomes have been shown to improve when providers incorporate appropriate communication techniques into their daily practice, and 90% of the battle is won in terms of having a patient as a trusted member of their wellness journey when we communicate effectively, empathetically, and in a patient-centered way with our clients. Thank you. That's the end of my presentation, and there are our references.
Thank you very much, Dr. Violet, for that presentation. Indeed, what is coming up is the importance of engaging our patients and giving our clients their voice. Just that what you're seeing is
I'm not able to get. Is there the one that is?
Hello, Mr. Kibet. Sorry, I've not been able to get you on the first bit. I think our internet had dropped off, but you're back on.
Yes, I'm back. Thanks. So it's who is presenting next?
Yes, Mr. Kibet, you're the one presenting. Are you able to share your slide?
Yes.
Yes, karibu sana.
Are you able to see my screen?
Yes, we can be able to see it. Thank you.
Thank you. So good afternoon, everyone. My name is Walter Kibet. I'm a quality improvement specialist with a few background in clinical medicine and also doing MSc in health systems management. currently on independent practice. I used to work with AMREF, so my experience will be based on the AMREF experience that I've had. So my outline will be very brief. I know the presentations that have been done by my predecessors are actually discussing what I have put together, and maybe I will give a community experience, because that is actually what I have in mind. So I'll look at the effective communication and what clinical practice entail, and then the components of effective communication, specifically on provider and patient engagement, and then providing community level experience. So when it comes to effective communication, we are looking at three things. One, effective communication is an art and also a skill that we learn. It's a two-way, where you're looking at the patient sending information to the provider, and then the health provider interprets and then gives feedback. Because with effective communication, as earlier has been shared, it is important because it helps in delivering health, without which, if we don't have effective communication, the quality of healthcare is at risk, and the healthcare costs may go up and also may have negative implications on the patient outcomes. Sometimes the actions done could be actually a risk, a safety issue to the client because of effective communication alone. Looking at communication being said, it's two-way, therefore each player needs to play a key role. Number one, in terms of the effective communication, is the patient need to convey the information that is actually the presenting complaint to the health worker. And on the other hand, the health worker must be able to adequately also understand and interpret the information and then provide feedback. And this could be really very important in order to decrease the risks, because without effective communication, there will be risks that are related to complaints, healthcare worker doing maybe a wrong test altogether, and even communicating feedback to the client. And so this is a two-way activity that really needs to happen at community level, at every level that we are looking at, level 6 facilities, 5 up to 1, up to even community level, where we have community health workers. In clinical practice, we are saying what we do on a day-to-day basis, dealing with real patients and relating to the history taking, examination, diagnosis, treatment, and even referral, is what entails effective communication. How do we deliver that information to the client, to the family, and even to communities? So in the community level, we are looking at three components. And I want to summarize by saying, for effective communications, there are three things that need to come into play. One is healthcare education, the cultural of the patient, and also the health system itself, and then the barriers relating to language. So having mentioned that, and having listened to the presentations made earlier by my colleagues here, then we are looking at, there are many things that come into play. And having mentioned the culture and education being important and patient education as critical components, I'll be able to share what experiences exist in the community level. For effective communication and engagement, we need the patient being able to provide information about their ill health and the healthcare status that they are. And therefore, this means that healthcare providers, on the other hand, be able to synchronize that information in terms of the presentation, and then provide diagnostic evaluations and confirm diagnosis, and therefore provide timely treatment. That in community level includes timely referral, because if it is a medical emergency, then action needs to be taken in terms of referral to an higher facility for immediate action. Now, three things that I have observed at the community level. Group counseling and education provides effective communication. This has been also demonstrated in chronic care models, specifically HIV, diabetes, and hypertension clinics and management, where group or family participation is also associated with greater success in the management of the clients. So for effective communication, there must be really a lot of engagement. And this is, as earlier been said, that using medical jargon becomes a challenge and needs to be really synchronized. So that needs to be considered in terms of whether we need group or family participation as well. On the level of individual counseling or effective communication, again, at that individual level, there needs to be one, seeking consent from the client, whether to allow or even deny, actually allowing them to make decisions as to whether other people need to participate in their management. Sometimes the patient believes and values may deny, may even demand that the client should not have another family member coming in. So seeking that consent is very important. Otherwise, sometimes you will realize that the client could actually refuse to open up and communicate effectively because of those kind of non-participate, actually allowing someone else to participate in the patient management, whether they are interpreting in terms of language or they are just accompanying the patient. Because of patient rights, that needs to come out clearly. The other thing that is important for also effective communication is reassurance of privacy, of confidentiality, that whatever you are going to do with the patient as professionally required needs to be really, reminded to the patient that that is still the situation. Because sometimes effective communication will not happen because the client feels that their confidentiality and privacy is not assured. And so repeating that is very important. The other thing also at the community level is never charge or make a patient feel that they made a mistake. We are good at actually correcting the things as they are, yes, but that is very risky at community level because you close out the patient from opening up. Sometimes a patient would tell you, I remember a situation where a client came, he had a breast growth and actually a discharging one and a wound. And the client would easily say, I was hit by a cow a long time ago, and that's why I have this wound. Yet it was actually an active advanced stage breast cancer. So basically correcting them when they are communicating could easily put them off, and therefore they will not be able to communicate effectively. The other thing is about gender barriers. As earlier been mentioned again, being a male health worker serving a female patient, sometimes in certain communities, it is an abomination. It is unacceptable, even religiously. So you actually need to be very careful so that you do not breach that gap and the client would be able to have a problem in terms of communicating again. And that means you seek for another person to serve the client that is comfortable because of their cultural belief. I've finished and I thank you for listening. I look forward to engaging more so that we are able to see how can we improve actually communication, because at community level, it's very sensitive. It includes also demystifying that in community level, people can have beliefs that if you are from certain tribe, then you'll only see clients more from that tribe that you come from. Sometimes demystifying that is very important because in a setup like Kibera, you have to be very careful because certain community levels could have higher number of certain, say, tribes or community members from certain tribe compared to the other. Coming out clearly and demystifying such myths and beliefs and misinformation is very critical so that patients do not take wrong information home. Thank you very much, and I look forward to questions and answers. Thank you.
Thank you very much for that, Mr. Kibet. We really appreciate you. Today we are talking about effective practice. One of the very important aspects in provider patient engagement for quality and safety. So we've had our first, we've had a basis on the communication from Mr. Siele, Mr. Newton Siele, he's the CEO of Phillips Pharmaceuticals, and he's given us a basis for effective communication. We have Dr. Violet Oketch, who has just taken us through about still more on communication, but how to put on the patient's voice in our engagement with them, and the importance of the patients communicating with us and the two-way feedback. And we've just had Mr. Walter Kibet, who has taken us through some of the community approaches and some of the approaches to effectively communicate with our patients. So you are welcome to give us the comments and the questions at the Q&A section. Maybe we'll start off with you, Mr. Siele. One of the questions that has come in is about how patients in this era of the internet get information. We have information overload, and we have patients going back, or our clients going back to the internet to seek answers. And sometimes they get the wrong information from those places. How do we deal with this as clinicians? How do we deal with this as we serve our customers? Thank you.
Thank you so much. That's a very important question. Normally, when we do the training on different types of clients, there's a sort of a subcategory. We normally call them as know-it-all, or we call them Google nowadays, I guess because of technology. And there are two ways you can look at it, actually. One thing is that for these clients that have taken time to go and search the internet about their condition or the drugs that they've been prescribed, it's really important that the clinician doesn't condescend, the effort that they have made. What we've seen is that when they feel like this is ignored, they are likely to be much more aggressive towards the clinician. Why are you dismissing the information I got? So what we normally advise is that first and foremost, listen to what they have to say. And secondly, it's good to thank them that they made that effort, because I think often clinicians would like patients that participate more in their care and therapy. And we've actually seen in certain cases that the patients even have new information that sometimes the clinician may not even be aware about it, because as we know, of course, the medical practice is often evolving at a very fast rate. So I think being able to differentiate allows you to listen. And as you said earlier on, listening is very important. You can be able to tell whether this is really beneficial, if it's new information, but thank the patient for taking time to read about their condition or the product that they've been prescribed. And I think that opens a conversation. And then, of course, at that stage, you can also inform them that not everything you see on the internet is correct. And we've had cases, for example, where people actually do put across wrong information on the internet. So they need to be extremely careful. But I think by being able to first acknowledge that they made the effort will make the conversation easier, as opposed to dismissing them, as we've seen in most cases. And I think that would be my advice. So I would say it tends to be double-edged in the way that you look at it. But the take-home message is, do not ignore that particular patient that has taken time to study. If there's something useful, you can take it actually as feedback. And if not, of course, thank them for taking time, but do remind the patients that it's often there's wrong information that is available on the internet. Thank you.
Thank you very much for that. And also an important point that we reminded is, when we are also speaking with our patients right now, it's good for us to keep up with the information. Sometimes they have read up with a new way of doing things that has come up. And so it's very important even for us as clinicians to keep up with the information that is out there, so that when these questions come, we engage them from a point of information and give them the best options that are available and the best information that can avail to them. Another question that we have is about those patients who get violence towards clinicians. And this one, Dr. Oketch will take us through about how do we deal with these patients who sometimes maybe have a mental disability, or one person who says here that they are in the methadone clinic, and sometimes they do. they do have patients who get aggressive and unruly. How are we able to communicate to them and calm them down and still have a good engagement with them? Thank you.
If you see a volcano boiling over, usually it's because there was too much pressure underneath, and that's why the lava is coming out. And behavior is rooted in belief and feelings and experiences that patients are going through. I think when somebody becomes violent or aggressive in a hospital setting, usually it is because of either they are feeling they have not been attended to, they're in a lot of pain, or they have a mental health disorder, or there is something else going on that is provoking that type of behavior. In which case, it is important to try and get a quick history of what the situation is. And the first thing that you want to do is try and establish rapport with that patient, listen to them, and try and talk them down and attend to the need that is actually provoking that kind of behavior. If it is something that is medical, then of course we need to attend to it. And if it is a patient who has a mental health disorder and they're not in touch with reality, or they have become very, very agitated because they're hearing voices, then there are well laid down protocols on how to manage such kind of patients. Thank you.
Thank you very much for that response. Indeed, we do get some of these patients in our setup, and we've also had some incidences where the healthcare workers have gotten aggrieved as a result of this. Another aspect or another question that comes up is in regards to the community level. Dr. Kibet, you can take us through this. What's the difference between group counseling and health education?
Thank you. In terms of group counseling, these are targeted counseling to specific clients with a common ailment. For example, you are talking of counseling for adherence to HIV treatment, adherence to medication in terms of hypertension treatment or diabetes treatment. So you are actually isolating a few number of clients into one place, and you are taking them through how to adhere to that treatment. And sometimes group counseling has also a component of feedback. There will be one-on-one experience sharing, and that also opens up in terms of actually strengthening treatment outcomes and even monitoring and long-term treatment. That one for chronic illnesses, it works very well for group counseling. Now, sometimes in the group counseling, either there will be more patients and one or two health workers, or even 3 health workers for also one patient. So it is either way. And actually that has also worked in chronic care models because it helps. In terms of health education, it's as simple as walking to the waiting bay in the consultation, outside the consultation rooms, and you actually have a topic that you want to discuss. For example, you're talking of maybe breastfeeding, maybe you're talking about malnutrition in children, any topic that you're dealing with, and you're dealing with a general population that is not isolated to one condition. It is an open discussion to a whole group of community who have come for treatment and they're in the waiting bay. That is what I call it health education. But group counseling is where now you are taking a number of clients to a small room somewhere to be able to have not only discussing the issues that are pertaining to the ailment, but also having sharing experiences for further management and follow up in their treatment. So that's what makes the difference. Otherwise, either way, health workers are involved and patients are involved. The other one is general, this one is specific.
Thank you for that clarification, Mr. Kibet. As we continue, maybe Mr. Siele, we'd like you to just give us a brief on how we communicate amongst each other in the corporate sector, especially. We have a question here that what about communication amongst healthcare workers? We have to talk amongst ourselves and not only to our direct customers. So a touch on how do we do intercommunication within our units? How do we talk with each other? even in the corporate sector, in the public sector.
Thank you so much. The thing actually is that the same principle applies even when we are talking about communications between teams. I think there's a topic maybe at another forum we could talk about, which is communication in corporate, as you said, especially from a leadership perspective. I think sort of just to put it into context, regardless of the person who is speaking or the person who is listening, one of the things that is very important is, of course, listening. In fact, normally when we talk about corporate, when we train on the 7 habits of highly effective people, for those who are familiar with that training, one of these habits actually is listening. I believe that's habit number 6, but it's habit number 5, I believe. You have to be able to listen first and seek to be understood before you can get somebody else to understand you. The breakdown in communication often comes in when we see this more from the leaders that are pushing down communication without necessarily giving way and being able to listen to the teams or the people that also want to give their opinion. And that then becomes a challenge. In fact, it becomes part of what we call a dysfunctional team. I think when it comes to customers, as I said earlier, understanding the kind of customers that we have is extremely important, because you will often be able to determine how to approach the communication aspect. And I think this has been covered by very well by the 2 presenters that we had today also. And being able to understand, for example, like I said, if you have people that are hostile, then your approach we're probably going to be more of listening as opposed to people who are very quiet and not talkative at all. So you need to use a lot more of open-ended and what we had said earlier, pauses in between, just to get them to be able to speak. So that also tends to apply actually when we are dealing with customers. But I think just to underscore, like I said, within the corporate, in fact, we see more problems with communication coming in from the top that doesn't allow for feedback from the bottom. That tends to become a common challenge. And in fact, as I said, leads to a dysfunctional team. But listening is, I would really say, is a cornerstone of any form of communication. And it cuts across, whether it's in the corporate, private, and I guess also within the public sector. We have been accused, of course, that especially those who've been in the public sector for a very long time, they tend to be used to talking. And I think a few years ago, we used to see patients complaining a lot that when they go to a public sector, they are screamed at, for example, whether it's in the wards, and they are not supposed to do anything there, so they're supposed to just listen and follow instructions. And we know, of course, that really is not the correct way of communicating. And I think that has changed over the last few years. Thanks.
Thank you for that brief on just how we should be able to communicate also effectively amongst ourselves for the sake of our clients and our customers. We have two related questions here. Now let's just Oketch to take us through them, and maybe Mr. Kibet, you can weigh in on that. We've talked about barriers to communication, and so one of the questions is what mechanism can we put in place to ensure patients with disabilities, especially hearing or speech, are able to communicate effectively with clinicians? And how can we ensure effective communication and counseling, and also getting history from a guardian where there is language barrier?
Hello. Thank you. So let's deal with the thing about communicating with patients with disabilities, such as hearing or seeing. One of the first thing is taking the Boy Scout or Girl Scout motto of being prepared, realizing that not every patient who's going to come to our facilities are going, we might get patients who are hearing impaired or seeing impaired, and therefore first making the grounds and the environment user-friendly for people with disabilities, having staff who are trained in sign language for patients who are hearing impaired, and giving priority, of course, to patients who are obviously having disability in terms of their ability to see or in issues of sight. And then I think signage is very, very important. I'm talking about the built environment being user-friendly for people with disability, having proper signage, having staff who are trained to handle in sign language and to handle people with in sign language, and also to have all staff being sensitive and aware to give priority to people who have a disability so that they're able to access care in a way that ministers to their need. The thing about counseling a patient who has a guardian, I think the issues that come up there are issues of confidentiality and who the patient wants to be involved in their care. Bringing in somebody who's able to communicate in a language that the patient understands, and giving them adequate time, space to be able to process what you're telling them and get feedback so that we are actually all on the same page. Perhaps one or two of the other panelists would like to comment. Thank you.
Yeah, yeah, Walter here. I wanted to contribute. Thank you, Dr. for that part. For the caregivers counseling with minors or those who are in any, this is a very common thing in setups like Ibera, because you'll find school teachers accompanying children to clinics for treatment, and sometimes the counseling required may not be beneficial if the caregiver is not going to stay with the client or the patient. So somehow we have circumvented that by writing a note and giving it to the child so that they're able to actually get a caregiver that is family specifically able to stay with them to accompany. Sometimes you find a neighbor is bringing a child of another neighbor. So those are very common things, and we need to be very careful. Part of our approach is doing an HIV test to those children. Sometimes you cannot, because one trying to do that then would mean whose benefit is it? So sometimes we only give a note to the minor who has come. They're not saying, please, the caregiver, or if they are staying with a relative or their parents is busy in industrial area, we ask them to accompany their child the next day or another day that is closer, so that we are able to serve them effectively. Otherwise, we can create an environment of, I would say, actually breaking the privacy of that particular minor, or even actually causing some more injury to the patient rather than helping. So that would be very important. I agree with you that there again, that other than also working with a trained colleague or disabled, for example, not able to interpret well, is referring that client also. In our setup, we are allowed to refer to have a setup that has also a trained colleague so that they're able to get effective treatment and support, so that we do not just do it. Unless it's an emergency, you can help in the emergency, but in a stable state, we can refer.
Thank you very much for those responses. And yeah, it can be a very real situation, and actually come across it whereby I've gotten a patient who was not able to speak, and I having to get someone who understood sign language took some time. In our institution, we do have been made aware that we do have staff who have been trained in sign language. So when in our clinical practice, when you get such a challenge, please do make a call to the marketing and communications, and you'll be able to be connected with one of the staff who is able to do sign language, and you'll be able to, and that way you can communicate to your patient more effectively. The other thing we've been told is about signage, having proper signage, and also, yeah, just looking for help if not able to understand that, and of course, taking into consideration the confidentiality of the patient. Now going into issues that matters actually on privacy and confidentiality, we do have a question here. Maybe Mr. Siele will help us with this. How do we balance? How do we make sure we balance between giving information to our clients while ensuring confidentiality, even as we pass information between us team members and information also to our clients?
Thanks. In fact, I was thinking, and I want to believe that Dr. Oketch will also put in her input. I think what is important is to also consider what the law says, especially when it comes to sensitivity and confidentiality, so that you do not do something that of course can lead to litigation. And I think I can see across a number of the questions that some of our colleagues are asking, including of course, even when you have minors. So I think the information that you're passing on to a patient should be the information that, of course, is directed at that particular patient. I think we have to make sure that we follow through all the requirements. I see a number of the institutions have already SOPs, even for information that may be asked. For example, even if the patient either herself or himself is not in a position to get, for example, it could be confidential information, then you need to make sure that there is actually a legal path that has been followed so that that information can be shared without the risk of thereafter leading to litigation. I think that is important. One more comment, I think, before I hand over to Dr. Oketch. As I said, we do have something that I also believe Kibet mentioned in his presentation, which is culture. And in some cases, we've seen even spouses that don't want to share information to the other spouse. I'm not an expert from a legal perspective, but I also do understand that this is a challenge, especially for the clinicians. If somebody is not willing to share, for example, their medical status for whatever reason, you have to remember that there's laws that is related to it. And I think that even becomes more complex nowadays because of technology and electronic information that can easily be accessed at the click of a button. So sometimes you might send this information by the time you realize you have already forwarded. So it's important to bear in mind the legal aspect when it comes to confidentiality. And for me, I think the rule of thumb, of course, is when you're dealing with the patient himself or herself in front of you, then of course you can be able to share the information that the patient is is supposed to get with regards to their health and the care that they are getting. That is definitely their right. The issue is when now you have the involvement of either the other family, whether it's extended family or immediate family, and that's where you need to make sure that you follow through the legal requirements, and in some cases just double check with the SOP as per the institution. Maybe Dr. Oketch would comment.
Thank you, Mr. Siele. I think you've actually covered all the bases, but I think one of the things that we sometimes forget, because as healthcare workers, many times we are coming from the side of you're trying to help somebody to get better. You want them to get better. It is very important before you disclose any patient information to somebody else who is not the patient to ask their permission. That I think will cut litigation fast in half. And the other thing is that, like for example, Kenyatta National Hospital is a teaching and referral hospital. And therefore, part of our mandate is both as we teach, we also train. And therefore, when we do ward rounds, we will discuss patients in the presence of other patients. But there are issues about that patient that might be very sensitive, which one would need to take time aside and in a one-to-one confidential space, impart those issues to the patient. Now, there are certain areas where the confidentiality of the patient would have to be waived if the condition that they have is likely to also impact somebody else, for example, their intimate partner, in such a way that it is endangering their lives. In which case, first of all, the guideline would be to get their rapport, find out where they are, disclose the information, and then walk with them in a journey to the place where they're able to disclose. But also warn them that at some point, if the barriers have become very high, and this is where counselors come in, because counselors are very, they are trained and skilled in being able to help clients reach a place where they're comfortable sharing sensitive information with their significant other. If their illness is going to significantly impact their significant others, such as, for example, you're a discordant couple, or they do not know the status of the others, and one partner has got HIV, it might reach a point where, in the interest of the significant other, confidentiality might need to be broken. But I believe that bridge has been crossed a long time ago in Kenya, because nowadays, for most people, definitely in reference to HIV, we regard it as a chronic illness of the times, and many people are living positively, long, healthy, and happy lives together, whether they are concordant or discordant. And that was just one case in point. But otherwise, confidentiality is really an important issue for everybody involved, but especially for our patients.
Thank you very much for that, for those responses. And also just to add, as a teaching and referral hospital, for those, we do have the students And sometimes seeking permission is really key, as you have been told, from the patients, just informing them that yes, these are students, and seeking their permission, they do have a right to answer. And in that regard, there's also a form for the same, whereby the patient can sign for it or against it. Just say if they do want, that explains the process of having the students in their presence and being taught. So not just to be abrasive and go ahead and have discussions in front of them, in front of the student, which might actually also border on breaching on confidentiality. Right now we are winding up on this session, whereby we are discussing on matters effective communication in clinical practice. One more, Mr. Kibet may help us in the community setup. There's a question here about on the community setup and in the pharmacy setup. How are we able to communicate to our clients who come to the dispensaries? And you might need the pharmacist or the person giving the medication needs quick information on what the patient is ailing from, which might not come out clearly. How do we streamline those systems?
I didn't get you on the part of pharmacy. What exactly?
I'm trying to get the question, but what happens is sometimes as our referral systems are not, our referral system currently still being streamlined, and we don't have a proper referring system. So we do have a lot of over-the-counter prescriptions, or we do have patients being referred from one facility to the next, and they don't have their histories written there or their correct information written there. And so how do we bridge this communication gap in terms of the referral system or getting the information from the client at the point of care?
Thank you. In terms of actually looking at communication at that level, one important thing is if the client is not able to understand. Sometimes if I realize that I have a communication challenge here, a client goes to the pharmacy to pick the medication, I need that client to come back to me, and then I ask them, how will you be able to take the medication? And sometimes it helps a lot because most of the clients may not have really understood, because I know of a scenario where a client would say that the medicine is written 2 times 2. So they will choose to take all the 4 tablets. One is in the morning, and that is for them how they understood. So basically paraphrasing and making sure the client is able to actually understand is very important. Number 2 is actually with that level again, walk to the other department, assist in the, if you know there's a communication barrier, assist in the passing of the message to the client to another to colleagues so that they're able to actually understand and be able to assist. Sometimes we refer and then we find the clients not delivering the correct information, or clients pick one information in one department and a different information in the other. So if a client really trusts you and has given you full information, assist in the management of that client by approaching the other colleague, not necessarily directly with the client, but even alone prior to. You can go and see the colleague, explain, and then you will have assisted the management. Otherwise, it is good to identify barriers to communication, effective communication at the patient level, at the facility level, and in the referral process, including sometimes if you ask a client to go to a higher facility and then write a referral letter, they will not go. So sometimes we have to consider all that when we are making a decision. It is a very tedious and a very complex scenario, but in the community, it is not very easy. It needs a lot of high index and also colleagues who are able to really, put themselves in the patient's shoe and be able to give what we call authentic support to the clients. Thank you.
Thank you very much for that. As you wind up, Dr. Oketch, this one is a timely one. In case you're seeing an adolescent with the parents, how do you safely excuse them? How to allow proper history from their young one in sensitive matters without their victimization later? In terms of communicating to our adolescents and where we drew the line between these are their caregivers, these are their parents, and the information that you are giving them.
Thank you for bringing that. That's very important. I believe most of them have passed through adolescence at some point in their lives before they became adults. And the way we handle adolescents and their caregivers is first, when the adolescent come in, you allow you talk to the family, they let the person who's the family spokesman talk about, why they're there and why they have come to be seen. And then after a while, then just excuse the parents or the caregiver and say, thank you so much for sharing what you feel your view is about what the issue is and what kind of help you're seeking. Allow me to spend a few moments alone with the child or with the adolescent so that we can also hear their side of the story. And then when they leave the room at that particular point, then you do reassure the adolescent that whatever you're going to discuss with them is confidential, and they are free to share what is in their heart and what they feel that the issue is and what kind of help they would want, or what they're experiencing, and that you will only disclose to their caregivers what they are comfortable with, and you keep to that agreement so that you're able to, as I said, build rapport and trust. And then you will then use your wisdom as a clinician or as a person who's in the medical profession to choose which aspects of what they have shared you can be able to share with the parents or with the caregivers, yet still safeguarding their confidentiality in order to maximize care.
Thank you.
Thank you for that response. As you're winding up, Mr. Siele, you can help us with this. When communication has not gone the right way, and we have a question here in regards to what if you have inappropriate communication upwards from the bosses, you have conflict within your team, and mostly conflict within like the management and how they communicate downwards, and where they communicate downwards, and also how the communication goes upwards. Maybe just a comment on that.
Thanks so much. I think, like I had said earlier, one of the biggest challenges that you would face is where you have a dysfunction in a team. And I'll just mention two dysfunctions. One of them is lack of trust. And lack of trust means that people do not want to speak up, either because they fear they're going to be reprimanded, or there's just no room within that team, for example, or the organization for them to be allowed to speak up. That tends to stifle communication a lot, and it really becomes a problem. And I would sympathize with an individual because, if this is especially being perpetuated by the leadership, it really becomes very difficult. Ideally, it's important to have an honest and candid conversations within a team where people do not have to hold back their feedback or their thoughts because they fear to be reprimanded. The second dysfunction that we see is often what we call fear of conflict, right? And in fear of conflict, again, people will not really want to speak up, for that matter, be free when it comes to communication, because they do not want to have any conflict within the team or the organization. So the two are sort of related, and that equally tends to really stifle communication within the organization. So again, the only way to be able to address that is that it has to really come from the leader. And I guess that's why even when we normally teach on communication, we put a lot of weight and emphasis, because there's a huge responsibility by the team leader or the organizational leader to ensure that these dysfunctions are addressed and that people are allowed to really be very free and communicate as much as they want to without fearing either to be reprimanded because of their thoughts or their opinions, for that matter. But I wanted to make one comment, I think, in conclusion from my end, because I saw that there was a question about difficult patients. So for that matter, we know it's also difficult customers or clients. What is important to remember is that do not label the behavior, but, I will label the behavior, but not the customer. We often have a challenge with the behavior of the client in front of us or the customer, but not really the individual themselves. It's the behavior you have an issue with. It's a behavior you want to address. But we've also seen that listening really is a very good antidote. Often, if you listen, you can really be able to diffuse. And it's not advisable to get defensive or take it personally. I think with that, you can be able to even communicate with difficult clients, patients, or even their guardians that may come, for example. So it's really important to also offer alternatives or at least solutions to their issues. But the key word is listening. Thank you.
Thank you very much for those comments. We are now coming to an end of our presentation today. And we've been able to delve into a lot of matters regarding to effective communication, and a lot of questions also that relate to how to deal with aggressive patients, how to deal with difficult clients, how to deal with the dynamics of communication within the organization, and some of the barriers to communication. And we really thank you for this. As we come to an end, we'll have our last comments from our presenters, and maybe Dr. Oketch, you can go first, as even give further information about the difficult patient, and comment on when do we as healthcare workers seek safety first.
Thank you very much for this opportunity to be part of this presentation. I've really enjoyed it. And I'm very, very happy that Mr. Siele has pointed out that we should not label a patient or a client as difficult. We should label the behavior. There is nobody who comes from their house coming to the hospital intending to be difficult. It is our perception that they are not meeting certain expectations that we would expect them to behave or do as a patient that makes us label them as difficult. And therefore, I would rephrase that or reframe it and say that when you come across a patient who is appearing to be difficult or a client, I would reframe it and say, this patient or client seems to be experiencing a challenge. How can I address it? And that is the way in which when you look at it like that, then we're looking at it as a growth mindset, and you're looking at it in a way such you're actually partnering together. And as Mr. Siele said, listen, listen, listen. Keep quiet. I can tell that you are going through a difficult time. You look angry. Please help me understand what is happening and how we can be of help. Just even your tone of voice and the words that you use can diffuse the situation. And then you gently bring the person back to be on board. Now, you might also find that as a caregiver or as a healthcare provider, that you're meeting a patient and you're not quite rhyming and they're starting to get on your nerves. It is important to be self-aware yourself. If you come across a situation that is triggering you, it is okay for you to politely excuse yourself and get some time for yourself to cool down, or ask another team member to intervene in that particular situation. Is the last question that you had asked, Dr. What was that? There was something.
I think it was in the same aspect of aggressive patients. A last comment here about when do we seek safety first as healthcare workers when we meet aggressive patients.
The answer to seeking safety first is, if you feel you're in danger, leave the room or call for help. Okay? Because by the time a patient, it is not very often that a patient suddenly becomes aggressive. Usually a situation is escalating, but sometimes somebody can actually become violent. And we need to have protocols in every place where we know how to handle violent or aggressive patients. And sometimes it also comes to be violent or aggressive relatives, especially when there have been losses or people feel misunderstood, disrespected, or that their needs have not been met. The other thing that would help in making sure that everybody is on the same page is to also have signage put up prominently that we will not tolerate violence towards our staff members. But remember that if you feel that you are in danger as a staff member, you are entitled to leave the space for your own safety and to call for your help and to see how to handle the situation. Thank you.
Thank you very much for that, Dr. Mr. Kibet, so give us your comments as we wind up, and maybe also touch briefly on the confidentiality in regards to how we inform our partners on issues as clinicians when we give results to one part to to our patient and they have a partner that they don't want them to know? Maybe just a touch on that as to give us your closing comments.
Thank you so much for being part of this team from Kenya. I really appreciate. I feel honored to be part of you. I just wanted to make a few remarks and for parting shot. Number one is, let's take time with our clients to listen and take actually a lot of time with them. Sometimes we have so many and the clients waiting in the queue, and so clearing the queue without service is not really professional. So take time with your client, listen, and you'll be able to assist them. And then work with what you are able to. Always be sensitive to matters when it comes to communication, when you're dealing with a third party. In the community, we have people called community health volunteers or health workers. Those are not people who took oath of office or oath of profession. And sometimes when they hear what we mention as health workers, they will go around with it and tell everybody else. So please, it's good to be sensitive that such information should not be divulged, even if they are part of the team in the health facility. Number three is, let us avoid delegated communication. Health workers, we have various levels. We have been blessed. We are the consultants. We are the specialists in the area. Please don't delegate information to a junior staff to communicate to a patient. If you can, deliver it yourself. You will save, because sometimes the messenger and the message may not go together. And sometimes when it comes from the senior most, it reaches the patient more comfortably than being sent maybe the nurse or the one in charge in the department to deliver the message. And finally, let us avoid what we call putting personal values in communication or management of a patient. Sometimes we put our judgment and our values when we're making a decision, and this affects the communication process. Let's be very careful, because this affects how we will be able to remove ourselves from a situation and look at it in a bigger picture, serve the client. Even if you have a personal value that is different from what the client has, respect them as they are, because they are humans and they have also rights to whatever they choose to. In parting shot, you are mentioning about the third party, the issue of confidentiality. I've mentioned that dealing with third parties is very critical. We need not to really bulk information to other people. For example, when a client is actually, I had a case where a client who is a teenager has not received, she's been unwell and has not gone to school. But when I examine, I have abundance of around 24 weeks. And I ask the client to go for some tests. When they come back, they come with a negative test. I had to repeat again with some support, and then I got the results. But the client told me not to ever tell the caregiver who was available. I respect the client's opinion, but in terms of management, I really sometimes have to be very careful that you do not injure. Because if you notice, in Kenya today, we have many people who are even committing suicide, causing what we call intentional accidents because of the way we manage health information. The method of which we do things is changing. Let's be very careful. For example, when we manage the issues of partner notification testing, where you are testing HIV contacts of a positive client, if you communicate badly, the other party can easily be violent and can even cause injuries and sometimes even suicide. So let's be very careful, because whatever we do can really injure and even cause loss of life. Thank you so much.
Thank you very much for that, Mr. Kibet. Mr. Newton Siele, karibu sana. You can give us your closing remarks as you wrap for us the session. Thank you.
Thank you so much, Doc. I believe that the two panelists have ably been able to summarize what we have discussed today. For me, I think the take-home is that we have the burden and the responsibility to make sure that the communication really is beneficial to the patient. I think we are enlightened, and for people that are enlightened, they need to make sure that they provide an ambience and an environment that allows the patient to feel comfortable for the communication to happen. I think with that, then you can actually say that we have proper communication. I want to finish by saying there are three levels of listening, and that's what I want to leave the participants today in. Level one of listening, we normally say you are 100% tuned in. It means that you actually sit back and give the other person opportunity to talk. You don't judge, you listen with the intent to understand. That is the best level of listening. Level 2 of listening, you are 50% tuned in. So you're half in and half out. And this is the one that we normally say you have to remove the barriers that you have so that you can be able to get back to level 1 of listening. We are human beings. And I think as doctors, you will often have many patients, some even in critical condition. So sometimes you've just left maybe intensive care, you need to go and see another patient, and you're still thinking about your patient who is on life support. So that is very human, but might not necessarily be very fair to the patient who needs to get 100% of listening. So level 2 of listening is just a reminder that you can get to 50%, but try and keep pushing yourself back to 100%. Level 3 of listening is the worst, and it's where you're completely tuned off. In this case, you can even be seated with a patient, they are talking, but you are absolutely not listening to anything at all. And it's a worst level of listening. It's not the one that you would want anybody to give you, and certainly not the one that patients would want to get from their doctors. So my request, I think, to the audience today is let's try as much as possible to give our patients level 1 of listening. And even when we get to level 2 sometimes, to really be able to remember that you can get back by removing the barrier, whether it's a phone, it's a phone call, maybe you're being called by the ward, or it's your thoughts that are taking you back to your previous patient, to try and ensure that we really give the patients in front of us the best level of listening. Thank you so much.
Thank you very much for that. We have now come to the end of our presentations today, and we've been talking about effective communication in clinical practice, having candid discussions on matters communication from Mr. Siele, CEO Phillips Pharmaceuticals, Dr. Violet Oketch, a mental health specialist, and Mr. Walter Kibet, a quality improvement specialist. And we really appreciate their time with us and the nuggets that they've left us with. We need to put this into practice to ensure that we communicate effectively and engage effectively with our patients. We'll have another session tomorrow in the afternoon at the same time, 2 to 3:30 p.m., whereby we are going to be talking about effective complaint management and organizational strategy for client delight. It will be also a packed session, a very informative session. You're welcome to join us. Thank you, our participants, for staying with us. Do have a lovely evening. I'm Dr. Karingo from Kenyatta National Hospital. Thank you very much.
Bye.